So, panel members, Mr. Quo from Birmingham, Mr. Hartley, Mr. Albert's just come into the waiting room, Mr. Bateman from Manchester, Hassan Ismail Cock from Southampton, and me, okay? So, just to remind anybody who hasn't heard already, if you're not a panel member, please mute your audio, otherwise it's going to be terribly noisy. If you want to ask a question, there is a chat function on Zoom, and you could type a little message in and it comes up in the sidebar so that we can try and address that. Now, it might be that we're not able to address that because we haven't got time, but we'll try to. There's also a function where you can raise your hand. Unfortunately, I can't look at that, so don't bother with that. Okay, so panel shows. Hassan, are you there?
Yes, I'm here.
That's fine. No, it's just you dropped out of the photos. So, Ben, 4-week-old male child at outpatients with stridor. So you're this is a patient you're seeing in clinic for the first time. All the registrars are away, and you actually have to see a new patient with stridor. So, what history are you going to try and elicit?
Okay, so the first thing is it truly stridor? And usually the patients have got a video clip of the noise if the child isn't making it constantly, and try and distinguish stridor from stertor or more nasal noise, which is sometimes called snuffle. So straight away, clinically, you can start to work out whether this is a laryngeal or a nasal problem, because nasal problems are quite common. If it's truly stridor, then a little bit more about it, how much of the time it's present, whether it's positional. Laryngomalacia has a very characteristic positional stridor, which is better on the side or better prone.
So this is definitely stridor. You can establish that fairly quickly because you can hear the baby as it's crying. Mum reports it's worse when the baby's on its back, so they tend to lie on its side. So that's pretty much taken as read.
Okay, so then a few questions really homing on the severity of the problem, whether there's associated tracheal tug, subcostal recession, and very importantly, how it's affecting feeding.
Yeah.
How long that child is taking to feed, whether they're breast or bottle. And weight gain, and whether that's been plotted on the growth curve. Then the usual questions about symptoms of reflux, regurgitation, associated medical conditions or any other congenital anomalies, and obviously then focusing on the more wider birth history, whether there's been any intubation or any other neonatal problems.
Okay, fairly standard stuff. I think we've covered that. So here is the history given to you for normal pregnancy. Absolutely no problems at all. Wasn't intubated at any stage. No medical problems, and the child basically maintaining its weight and growth velocity, but it tends to throw up a lot. Mum says she thinks it's got reflux. So Neil, what examination of the baby are you going to undertake next?
So it starts off with an examination of the whole child to get an impression of how the child is, how severe they are when you see them in the clinic. So I'm looking for, as Ben said, signs of tracheal tug, recession, intercostal, subcostal recession. I think it's really important to have a good look at the whole child, look out for hemangiomas, things on the skin, and I think a fibre optic laryngoscopy done in the clinic is an absolutely critical part of this. So it's basically a good look at the child, get an idea as to how they are, as to how bad things are, and then move on to a fibre optic laryngoscopy.
Okay, so you're examining the child, and you see a hemangioma on the leg, little 5mm red thing. Otherwise, the child looks pretty chipper. You make it cry, inevitably, and you can see a bit of tracheal tug, but not much in the way of sternal recession or anything more serious than that. And it looks like it's got a fairly decent airway. Okay, so what examination next? Did you say a flexible nasendoscopy?
A flexible laryngoscopy in the clinic.
Okay, and what sort of nasendoscope do you use for that?
We've got a little pediatric short.
Oh, I think someone may have just joined that needs to mute. I'll just have a quick look now. That's a very rock and roll moment there. You've got a small pediatric scope.
Yeah, a pediatric scope. I think it's incredibly difficult to do this without a pediatric scope.
Yes.
Getting an adult-sized scope down the nose is, I think, pretty hopeless. You can get an adult scope into the mouth in children, but you just don't get a very good view.
Yeah. Can you still hear me? You went a bit quiet then for a minute.
No, I can still.
Oh, that's perfect. Okay. Yeah. So that's, you use a pediatric nasendoscope through the nose, which is that's the standard. In our hospital, it seems that the pediatric nasendoscope is regularly missing or broken, or off for repair. So how would you do it if you only had the adult 4mm one?
So what I generally tend to do is I pop that through the mouth. If you put your finger in and just put your little finger into the baby's mouth and then slide the adult endoscope down the side of the finger and then just get that to the back of the mouth, you can very often get a view of the supraglottis that way. I don't think you get such a good view as you do with the pediatric down the nose, but
yeah. Okay. All right, fine. So now suddenly a load of people have found out the correct meeting code. So we've got lots and lots more participants now. If I could just remind them all to keep muted if they could. Okay, so this is where we're going to try and get the video to run. Here we go. So you're nasendoscoping this child with your pediatric nasendoscope. Can you describe what you're looking at?
So this is very typical laryngomalacia. We have a tightly curled tubular epiglottis with short aryepiglottic folds and some posterior tissue over the cuneiforms, which is collapsing inwards. It's sufficiently tight that you don't really get a good view of the vocal folds. The other thing that I'm really interested when I'm doing a flexible endoscopy in the clinic is I just want to rule out any other pathology. The main reason I'm doing this is I want to make sure that we haven't got a molecular cyst or something else that's going to cause problems. So that's really typical laryngomalacia.
Okay. Now, that's fine. So a question at this point for you is that a lot of pediatricians traditionally have been happy to manage newborn stridor just on the history examination without a nasendoscopy.
Yeah.
And are happy to just label it laryngomalacia. Do you think that's appropriate or not? Do you think they should all have a nasendoscopy?
They never get through my clinic without having a laryngoscopy. And I've just been caught out so many times by thinking this is probably laryngomalacia and finding a different pathology. So I personally think that if you have a child with stridor, it's pretty much mandatory in my practice that they have a flexible laryngoscopy.
Okay, that's right. No, I kind of agree with that. I think that you can nasendoscope all of them, so there's no reason not to anymore. Fine. Okay, so that's laryngomalacia to start with. Mike, Mr. Quo, tell us a little bit about laryngomalacia. Are you still there? Yeah.
Well, hello.
Yes, you're here, Mike.
Yeah. Can I? Can I be controversial about your laryngoscopy?
Yes, please do. That's why we're here.
I almost never nasendoscope anybody. I'm really worried now because I must be doing it all wrong. Because I'm not sure. I remember the last time I found something on nasendoscopy that I didn't expect to see. And I suppose it's partly because, and going back to what Neil was saying, we used to have the fine pediatric nasendoscope, and it cost, I think, £15,000. It lasted no more than 3 months, and
Yeah.
I just couldn't justify it anymore. And now we've got big adult scopes. Actually, I think I could, almost every time I want to, I can get a 3.8 millimeter scope through. But we've just recently got the tip chip one, which is only 2.4 millimeter, and of course you can't break it. Well, you sort of can't break it because of tip. So I do wonder whether I'm going to change my policy, because previously I just couldn't see anything because through the neonatal scope because it was broken all the time. And whatever efforts we try to stop anybody from anybody using it. And the other thing, of course, is that I think most of the time we get referred these from other places. The ENT surgeon, the referring hospital, is redundoscope. I suppose you have to decide whether you trust the finding, I suppose. But I suppose I know we're not allowed to say the word COVID today, but
yes,
I'm going to say it anyway. But I wonder whether that's going to change our threshold for doing it. But anyway, I just put it out there. And of course, statistically, as you put on your slide, 90%. If you look at Lauren Hollinger's, I think, paper, he's something like 95% of laryngomalacia. So actually, theoretically, without seeing the child at all, you've got a 95% chance of getting it right if you say it's laryngomalacia. But my teacher always told me that it's and Ken is tone deaf, so I don't know how he did it. He said you can always tell laryngomalacia by the sound of it because they make this strange, slightly high-pitched musical sort of sound. And I suppose as I see more, it does seem to be quite consistent.
It's interesting. I'm sure I've read somewhere that someone did a paper where they said it was fairly difficult to tell the different things apart. I mean, you do get a slightly more coarse rasp with subglottic stenosis allegedly, but I reckon you get...
And with cord palsies.
Well,
I think with cord palsies, I think with cord palsies, you almost get a vocal noise. You get a noise that sounds like a baby crying, and it's really loud.
Yeah, fair enough. Baby crying inside out.
Yeah.
Okay.
I don't know if it's ethical, but great, because you have your great big USB microphone. Maybe we should record all babies and actually see whether artificial intelligence, we can actually work it out. Just, after all these voice phonosurgeons have this shimmer and jitter and stuff that I can never work out. I'm sure it wouldn't be beyond, all possibilities to find out whether it's actually possible.
There have been a few ASPO studies recording stridor and sending it to pediatric otolaryngologists. And actually,
that's what I was getting at.
It's not very reliable, actually. No, endoscopy is definitely better.
It sounds like fun, though, I suppose. Anyway, good. So let's just talk a little bit more. So we've now got 46 participants, which is good. Sorry about the sort of slightly lumpy start. So laryngomalacia, as I'm sure we all know, commonest cause of neonatal stridor. Nobody really knows why you get it. Tends to be worse about 3 to 6 months. Resolves by the age of 2 unless you've got some other complication like Down syndrome, and it's associated with reflux. Now, one thing I'm very keen on is that the diagnosis is dynamic, meaning that you need to see the supraglottis moving. You can't just look at a static picture and say that epiglottis is a bit amoeba-shaped, because they're all a bit amoeba-shaped as far as I'm concerned. You want to see it actually collapsing. And the other thing you want to do is see the vocal cords actually moving, because that's, in my book, the primary differential. So, Hasna, are you still there? I haven't heard anything.
Yeah,
you're incredibly quiet.
I didn't want to interrupt. Yes.
Right. Are there different types of laryngomalacia?
So there are different types. So you can get neurological variant, which is usually present from birth. And I worry about that slightly, that the pathology is different. And then most laryngomalacia, like you're saying, that occurs at 4 weeks.
Yeah.
So in terms of, congenital laryngomalacia, neurological, but also you can differentiate it into the types of severity. I'm not sure if that's what you're asking, so mild, moderate, or severe.
Well, that's not quite what I was getting at, but it doesn't matter, because if I just show you the next slide. Have you seen this thing before? I think
Yes.
I've seen people talk about this, where they differentiate them into different bits like this.
So I find these quite difficult, I have to be honest, and I think it's very difficult to diagnose which is which. I think one of the things when you're talking about flexible nasendoscopy, one of the things that for me I found really helpful is videoing it.
Yeah.
And also trying to call inspiration and expiration, what's happening. Because one of the things that I've really been caught out on is when you're having things lower down that are causing negative intrathoracic pressure, that causes everything to collapse in, which can give you a false view of laryngomalacia. But I think with these different types, I find it very difficult. And what I try to do is work out in my head what is actually causing the problem. So is it the arytenoids flopping in? Is it the tight arypiglottic folds? Or is it a combination of everything? So I don't really use a grading system as such, although I know quite a few have been proposed.
Okay, no, well, I must say, I've seen this in articles and talks, but it's not something that I use in clinical practice.
Mike, I think it is quite important because we have different operations for different abnormalities. And if the problem is predominantly a short aryepiglotic fold, type 2, then you're going to snip it. If you've got predominantly arytenoid prolapse, you're more likely to trim it. If it's prolapsing epiglottis, much more complicated.
Well, that's I agree, that's a slightly different kettle of fish, but I find most of them are a combination of these two things most of the time, at least the straightforward neonatal ones. So I don't tend to make the distinction between the two in the clinical notes, for example. Would you do that? Would you say it's a grade 1 or a grade?
Not in clinic, but if it got as far as MLB, I would actually, I would generally, it's more descriptive, but there is quite a range of abnormalities. And the important point is that the simple snip doesn't suit all comers. And you'll get a very, very good response for tight folds in some, but if you snip the folds when the main problem is arytenoid prolapse, then you won't get a good response.
Okay, no, that's fair enough. Okay, now, so let's stay with Hasner for a minute, because you've been very polite and not said too much, but baby one, you send away for a few weeks, but they return a few weeks later saying things have got worse. Baby's choking a bit on feeding and making more noise, and is now dropping off the centiles when we weigh them. It's gone from the 80th down to the 30th. And at one point it choked and went a funny blue colour. So mum's clearly a bit worried. Are you going to change the plan at this point?
So this is following maximal medical therapy, I assume. So
well, we haven't got onto that yet. So what medical therapy would you start?
So usually I start off with aerophagia bottles.
With which one, sorry?
Aerophagia bottles.
Yeah.
So, for example, the MARM, the anti-colic bottles.
Okay.
Anti-reflux medication. So usually I suggest omeprazole, and if they're really bad, they can have infant Gaviscon.
Yeah.
Positioning them. If they've had an episode of cyanosis, I'm a bit more worried. Did this baby have any comorbidities?
No comorbidities at all.
No comorbidities. So if they are falling off their centile, then I would be concerned if they failed to respond to therapy. So if they tried all of that and had maximal medical therapy, 2 weekly weights, and they're having an episode of cyanosis, I would be concerned.
Yeah.
It would push me more to theatre and undertaking a laryngotracheobronchoscopy.
Okay. I think that's fair enough. Yeah. So the next step would be to consider going to theatre at this point, yeah?
Yes.
Okay, great. So those are what I've got as indications to intervene: failure to thrive, choking episodes, desaturations. Now, what constitutes a significant desaturation? I don't know. Does anybody have a handle on that? on the panel?
I remember Dana Thompson once saying when it was severe, you were looking at saturations of less than 86. But I think one of the issues for me is what is normal in a baby for saturations, and how are you actually monitoring these desaturations? It's incredibly hard to get an accurate study in a child, and you know, are you getting a correct reading? So I think it's very hard, and it's more for me by failure to thrive choking episodes, but work of breathing.
Yeah. Okay. Well, let's say you're gone to theatre.
Right, can I just note?
Please do, Ben.
Really, in clinic, I think it's very helpful to split them into mild, moderate, and severe.
Okay.
Mild children are noisy but are feeding well. They're thriving. They get a diagnosis and they get discharged, and they have to have regular weighing locally. Moderate ones are starting to get feeding problems. We're thinking about reflux treatment and follow-up. Severe are failing to thrive, and we're thinking about general anesthesia, MLB.
Okay, that's right. I think I probably failed to cover conservative management adequately there. That's fine. Neil, did you stick your hand in the air there?
I may be scoping too many of these, but to be honest, I think it's really important that we recognise that until we've done an MLB, we haven't confirmed the diagnosis. We haven't excluded tracheal pathology. We haven't had a really good. So I scope them under the anything else. If in my head, if they don't fit, if they have any additional symptoms which doesn't fit with the diagnosis of laryngomalacia, then they get a scope. So if they have episodes of cyanosis, if they have risk factors for acquired laryngotracheal stenosis, if they have any problem with the cry or obvious choking episodes, then I go straight to a scope at that point.
So I would add an extra line to that. If anything is atypical, they're coming to theatre. If they've got a typical history, a typical flexor laryngorrhaphy, then we can make the diagnosis constantly.
Exactly. But I think if they don't fit a textbook description of laryngomalacia, then I'm going to an MLB.
So there are papers discussing what the incidence of a second airway lesion is in this condition, and I've heard some of them saying it's 15% have another airway pathology as well as laryngomalacia. It's usually tracheomalacia in my experience, but so I suppose that's one of the reasons to go to theatre, is to rule something else out.
Yeah, but see, most of those series come from general anaesthetic MLBs in teaching hospitals, a highly selected group.
The
90% figure probably is a bit low. If you go into the community, remember we're only seeing a small fraction of the children with stridor. We're looking at incidence of laryngomalacia being more than 99% of children with stridor.
Okay, I think.
Well, you see, Mike, I think, Mike, to follow that also, you'll only see those because they actually made it to MLB. So actually, it's already highly selected.
So all the ones that get to MLB, 10% have got a second pathology.
Yeah, exactly. But also because those are the ones that the surgeon, like Ben and Neil, is saying, you know, they sound a bit atypical. So actually, you've got a feeling there's something dodgy going on anyway. So I think in reality, the synchronous other abnormality isn't that high, I think.
Yeah, I agree. And also remember that a laryngomalacia will induce a tracheomalacia because that's their inhaling. If they're inhaling against obstruction, they will get a tracheomalacia.
Yeah, fair enough.
Mike, just to ask you about the desaturations. When you say desaturation, are you bringing patients in for almost like an oximetry, or?
Am I? No.
So what do you mean by saturation? You clip an oximeter in them while they're feeding in your clinic, or?
Well, to be honest, it's a very rarely an indication for me. It's certainly one that's written in most of the papers about laryngomalacia. I suspect those tend to be ones that are on the ward, say they're on the neonatal unit already, and they're at the deep end because they're not putting weight on, and they've got a saturation monitor on them, and they phone you up and say the sats have gone down to 82 again. So, but normally, no, I'm not doing SAT studies on babies overnight. It's on the other things we discussed in the history.
Yeah.
Okay, so we're going to go to theatre, and presumably most of you would agree that if you're going to give a child a general anaesthetic and go through an MLB, you would consider doing some sort of surgical procedure at the same time. Presumably everybody agrees with that, do they? Yeah, fine. Good. So aryepiglottoplasty is the thing that we do. Neil, perhaps you'd like to tell us how to do it.
It goes back to what the type of laryngomalacia we have is. I agree with Ben. I don't tend to classify them as type 1, type 2, type 3. I describe what I see.
Yeah.
And for the majority of children, the problem is tight aryepiglottic folds and/or prolapsing posterior tissue. I do it, obviously, spontaneous ventilation on suspension laryngoscopy. I use cold steel and some topical adrenaline for anesthesia. I don't have them intubated, and I snip the folds with scissors, and then I debulk the mucosa over the cuneiform cartilages, trying to leave the exposed area, the raw surface, on the exterior of the larynx posterior.
Okay. Fine. Everybody else use cold steel? Does anybody else use a laser?
Yeah, a slight bugbear. I banned the expression cold steel because it sounds medieval. We do endoscopic surgery.
Okay.
Yeah.
You've got endoscopic surgery.
Yes.
Hot steel.
Hot steel.
Yeah.
I don't use anything. I don't use any expensive pluggable in tool.
I was about to ask you. Do you use the coblator?
I don't use the coblator. It's one of the few operations I don't do with the coblator.
I have to say, I'm somewhat surprised. Have you tried it?
I have, yes. And it works really well. It's just a very expensive way to do a quite.
Okay, that's fine. Well, okay, that's fine. So here's a picture from one of the many online publications. I'm sure most people will be familiar with this. You reduce the bulky mucosa of the aryepiglottic fold, and you divide the aryepiglottic fold itself there when it's tight, depending on what the abnormality is. Now, when people are learning about this the first time, there's a tendency for them to think that you're operating on the actual arytenoid cartilage, and you're not, because the arytenoid cartilage is right down there at the level of the vocal fold. You're operating on the aryepiglottic fold itself, which is a sort of floppy thing above the arytenoid cartilage. It contains two little cartilages called the corniculate and the cuneiform, and I think sometimes you remove one of those. Would everybody agree with that?
Yeah.
I never know which way round they are, but sometimes I remove the one that's in the way. Right. Mr. Hartley, then, what are the complications of this?
Well, you can underdo it or you can overdo it. It's better to underdo it. If you remove excess mucosa, you will get dramatic improvement immediately, but you will find gradual recurrence of stridor over the next few weeks and supraglottic stenosis. And supraglottic stenosis can be quite tricky to deal with. So that's the danger of excising mucosa over the arytenoids. It's a great danger of using the laser. And so you really need to be conservative with that mucosal excision.
Okay. So apart from supraglottic stenosis, any other complications?
I mean, bleeding occasionally happens, but it's generally minimal.
Mm-hmm.
Aspiration is a concern. It's a difficult one to measure. Any post-operative aspiration is nearly always temporary. Based on the background of normal children with and without laryngomalacia will have aspirations, episodes of aspiration. And so there's a whole spectrum out there.
Okay. Yeah. I mean, who else has had problems with aspiration afterwards? Anybody?
I think they always aspirate a little bit for the first day or so.
Yeah, but there are some that, I mean, my experience is that the ones that get aspiration on a long-term basis have already got a bit of a neurological problem at the start. The ones who don't tend to be absolutely fine. But I haven't had a huge amount of trouble with aspiration. I tend to be quite conservative. Those are the complications I've got: failure, supraglottic stenosis, aspiration, and one of the reasons I don't like cold steel is that I think it's a little bit more traumatic than the laser, and it causes more edema. Occasionally you make these children a bit worse, but that's not terribly common. So,
Mike?
Yes.
I think the thing to remember for those who don't do this a lot is that it's very easy to remove too much, because you need to pull the mucosa so it's under tension, so that you can cut it, but you can easily pull it too hard so that you remove too much. So actually, it's one of those things that I think you have to sort of practice a little bit. And of course, if you're a registrar with no great desire to do pediatric, you come through a service. It's not a great. It's quite difficult to get the tension of the of the other hand.
Okay.
But you can, that's how I think you can easily cut too much off, because you put it under tension in order so the thing cuts and not trying to cut cloth, and then you can easily pull up too much, I think.
So I'm one of the very few dinosaurs that still likes the carbon dioxide laser for this operation very specifically, and not for anything else, not for anything in the subglottis, because it's pretty superficial depth of burn. It's the only thing that touches apart from the sucker, and you can very nicely evaporate that mucosa there. And also, because there's a bit of burn contracture, I think sometimes it sort of everts the aryepiglottoplasty fold outwards. So I really like the laser just for this. It's pretty much the only thing I do with it. And we've got a very old laser because it's not really worth buying one of those super new ones anymore. But most people obviously go into cold steel. Anybody do unilateral still? There was a vogue for doing this to reduce the complications. No?
Occasionally, yeah. Occasionally I'll divide both folds and just trim one arytenoid.
Okay, that's fine. And well, that looks like quite an aggressive lot of lasering to me. But I have to say, I haven't seen significant supraglottic stenosis in my practice. I know it's something Robin Cotton talks about quite a lot.
So Mike, you might use the laser to vaporize rather than to cut.
Well, you cut the aryepiglotic fold with it, and then you reduce the bulky mucosa over the posterolateral bit of the aryepiglotic fold. You sort of vaporize it, and it disappears. You have to be very careful, and obviously you don't go between in the intraretinoid region. But if you're very careful with it, I think it's very effective, and you don't get any bleeding either, which is another thing I quite like. But I mean, mine, I've not had any complications, so I'm very happy with it. The downside is it takes an awful lot longer to do, because, as you know, setting up a laser takes a lot longer than opening a microlaryngoscopy set. Right, so very rare. For some reason I haven't got a video of this. Trapdoor epiglottis, or type 3, where the epiglottis itself is pinging in and out of the vocal cords. How do you treat that? Let's ask Hasna that.
So I haven't seen many of these where it bin lids, but Haytham Cover, where it bin lids over the airway, but Haytham Cover wrote this really good technique up where you sort of do 3 cautery lines on the lingual surface of the epiglottis to pull it back. I think you have to be very cautious, because the thing that would always worry me is aspiration. With managing it. The other thing is to trim the epiglottis. But again, your worry is aspiration. But I think if you do use cautery on that lingual surface, it just pulls the epiglottis back.
Yeah, that's one of the reasons I like the laser, because you can put some burns in and it'll sort of contract afterwards.
Yeah.
Other people describe burning a raw area in the vallecula and then putting a suture between the tongue base and the epiglottis, which I've tried, and it's actually quite difficult to do. Ben, Mike, Neil, do you have any experience of this?
So I've tried I've used the laser to do both the lingual surface of the epiglottis and the tongue base, and I put a stitch through it. But each time the stitch has lasted about, I don't know, less than a week, and then it will ping open. And eventually I have actually, I took a deep breath in and amputated the epiglottis after discussion. The child just couldn't cope, and the parents said, the parents said, I'd rather you have a go at that than do a tracheostomy. And maybe it was in the early part of my career when I was less wise and more cavalier. I did it, and I thought this is going to be a disaster. And he breathed normally and never aspirated a bit. So as my nieces keep telling me, it's more important to be lucky than to be good. So maybe that was just lucky. And I haven't actually seen such a bad one since that didn't manage with some endoscopic procedure.
Okay. In fact, the first recorded operation for laryngomalacia by Samuel Iglauer in the 1800s was to use a tonsil snare and snare off the epiglottis in outpatients. And he maintains there was no bleeding and the child was absolutely fine and went home straight away. Just a scary thought. Right. Okay. So this is the sort of thing that gets described. You use the laser, you cause some scarring in the vallecula, it contracts outwards, and you can or cannot put a suture in. People have described a few things, but it's relatively rare. Okay, that's good. Here's a video nicked from YouTube demonstrating supraglottic stenosis. This was actually after using the laser for something else, but it gives you an idea. And the problem with this is much, much more difficult to treat than laryngomalacia. So if you're going to underdo it or overdo it, you're better off underdoing it, in my book. Okay, I think that probably, we've talked an awful lot about laryngomalacia, so I'm going to move on a little bit. I'll pick on Neil again. I don't think I've picked on Neil very much recently. So, different scenario. Again, the registrars are all on a course and the SHOs poorly, and you're asked yourself to go to the neonatal unit, and having found it, you're presented with a 36-week-old prem. It's had stridor since birth, not in the first week. Slightly dysmorphic looking. It's got cardiac issues, and this child is properly stridulous with inspiratory stridor at rest, tracheal tug at rest, maybe a tiny bit of recession, and they've got it on high flow oxygen, and they're a bit twitchy looking at you. And the other thing that you notice is that when you're asking the nurses in the neonatal unit, which is the baby you're coming to see, you can actually hear it before they point you out. The stride is quite loud. So what are you thinking here?
So I think, I mean, as I said before, I think when the stridor is that loud, the diagnosis of bilateral vocal cord palsy is to the fore. With this child, I would want to know, firstly, what is the history of the stridor? Did it classically, bilateral vocal cord palsy will come on at birth. It's different from laryngomalacia in that regard. It will come on with the first breath. I want to know about risk factors for laryngotracheal stenosis. So has the child been intubated? If they've had cardiac issues, clearly you want to know, have they had any surgery for cardiac issues? Yeah. And do they have any other airway symptoms that might make you worry that there was some other pathology going on? And then my history and examination and my assessment is all about how severe is it? What are their markers of severity? The fact that they're on high flow oxygen would indicate that that's a pretty
quite bad.
Quite bad. If they've got loud stridor and they're on high flow oxygen to maintain their saturations, then that would make me think that this is something that we can't really sit on.
Okay. So in answer to those questions, they haven't had a heart operation yet. That joy is to come. The stridor was audible in the delivery room as soon as it came out, and it hasn't been intubated, but once or twice the overnight team have thought very hard about it, but been persuaded not to. So the child's really teetering along. What are you going to do next?
So I think my plan would be to go to an MLB at a fairly early opportunity.
Straight away, without a flexible?
Well, I have to say that my trainees would whiz up a flexible onto the NICU and have a look. My view would be, actually with this one, I'm going to be having a look down with an endoscope under anaesthesia, and I probably wouldn't.
Okay, what? Partly because you don't want to upset the child and tip it over?
Exactly. I think, we've got to...
How old is the child, Mike?
It's a 36-week prem. You've been asked to see it in about day 2. So, yeah, is that all right?
Yeah, in my book, the newborns, they're the best, but you just don't know what you've got. And it's exciting when you get a newborn with severe stridor, because these are the ones they can have webs, they can have atresia, they can have clefts, they can have bilateral palsy, and everyone's terrified of them. And we take them to theatre pretty promptly and scope them on the grounds that there could be anything going on down there. We see multiple anomalies.
Well, they certainly could be if they're at Great Ormond Street. I agree. In Bristol, perhaps not quite so likely. But I think, how many of the rest of you would do a flexible? I know Neil said he probably wouldn't. Hasna would? Yeah, Mike?
Yeah. Interestingly, having just said that I would not normally do one if I think laryngomalacia, I would do one here.
Right. Okay. Neil, we know you. Ben, would you do a flexible on the unit?
If it's a day or two old, no, they go straight to theatre. If it's been hanging around for a few weeks, and the flexibles, it's a good investigation for bilateral cord paralysis. It's not an easy diagnosis to make, and a flexible is a good investigation. But again, we see so many weird and wonderful things in the newborns that I'm going to be taking to theatre probably anyway.
Yeah. Okay. My guess is I'd probably scope it, but anyway, you've gone to theatre, and Hasna, what can you see here?
So this is a dynamic view with an endoscope looking at the vocal cords. You can see adduction. I don't know whether it's coordinate with respiration, what's breathing in or out, but this child isn't getting complete abduction. So this looks like a bilateral vocal fold palsy to me, but you haven't assessed the rest of the airway, which you'd need to do in the cricoarytenoid joints to check there's no fixation. And that's not causing the issue, and also the subglottis to check there's nothing splinting the vocal fold. Could I just ask?
Yeah, please do.
So, from my point of view, what worries me a little about these children, and this is to Ben, and I don't know if any of the people watching might. What do they think of this? But basically, when I look at these children and they're dysmorphic, it worries me a little bit that is there something else congenital, neurological or genetic going on? I assume the AVSD has been diagnosed by an echo, but neurologically wise, I've been caught out where it's a neurological issue that's caused it, and it's a very severe diagnosis. You take them to theatre and they do exceptionally badly because you've missed that, or would you just then tube them and get a further opinion or scan?
So once you've got this diagnosis of bilateral cord palsy like this, what further investigations would you do, Hasna?
So I would
always do a head scan.
So especially if they're dysmorphic, and you're concerned about their appearance. It could be something central. So I would do a scan of the brain. I would do it down to the aortic arch, but you do a full examination anyway. I would also ask for genetics and possibly neurology, depending on what you mean by dysmorphic.
Can I be a bit fussy about the terminology? I don't like vocal cord palsy. It tends to be an all or nothing. We've got bilateral vocal fold immobility. We've got paradoxical movement. We don't know this is a palsy. There may be other reasons that we get paradoxical movement, and you can get every range of paresis. And just to call it a palsy or not a palsy is a massive oversimplification.
What would you describe that as then?
Well, all I would say so far is we've got paradoxical movement.
Yeah, but on waking, there's no more. That's as much movement as you get.
Yeah, so and stage 2 anesthesia, you will often see paradoxical movement in normal children.
Yes, I'll come on to that.
So as they're awakening, you need to see very confident you've got paradoxical movement in the child that's awake and trying to inspire. And it's not all or nothing. Some children will have reduced movement. And so paresis is a really important thing, and it does affect the decision making, because probably some of the ones that are managing have got a degree of movement. And in terms, when we look at laryngeal movement disorders, the textbook ENT is you've either got a palsy or you're not. That's a bit like saying your legs either work or they don't. There's a whole range of abnormalities going on here.
Okay. I must say that's a subtlety that I don't necessarily appreciate as often as perhaps I should do. Let's just go on.
But in a way, does that matter? Is that affecting your decision to intervene, or is that affecting your determination of prognosis?
Well, I suppose if there's a bit of movement, you might think the prognosis is better, wouldn't you? That's the sort of.
But I mean, if the heart's a bit, you know, off target anyway, you might.
Yeah.
If the heart's a bit wonky.
Yeah. well, the thing what I was trying to get at when I asked Hasna was I always arrange a head scan of some sort, because the one thing that is treatable as a neurological cause is a Chiari malformation. Because the neurosurgeons will decompress that, and sometimes you can get the cord movement back. Most of these children seem to be pretty complex and wind up having either a cranial ultrasound or an MRI posterior fossa, either way. Does anybody not bother with a head scan if they've made diagnosis?
I was always taught to ask for an MRI, but our radiologist say an ultrasound scan tells me what I need to know. So I sort of stopped arguing, because you put in an MRI scan request for bilateral cord palsy. They say, okay, change that to an ultrasound.
That's the kind of radiologist's reaction to every MRI request, isn't it? Fight your corner. Yeah, but that's fine. I would agree with that. If they can get a scan through the patent fontanelle, that's fine. Okay. So what Neil, what are you going to do next? You've diagnosed it.
So you've diagnosed it, you've excluded anything intracranially. I would always get an MRI, to be honest. Radiologists are a little bit. That's
fine. No other airway lesion. It's bilateral cord palsy, for whatever you want to call it.
I think there's a general acceptance that some of these children will manage and some of them won't.
How many will manage without a trachea?
Well, the exam answer is 50%.
Yeah, that's what I always say.
50% manage and 50% don't. I don't know if that's true.
What do you think it is? What's the Manchester answer?
Series, 50% got better.
There you go. And I think there's a general acceptance that a significant proportion will get better with time, and some of them will need a tracheostomy to get them to thrive and to stay alive. Mm-hmm. So it comes down to, are they feeding? Are they thriving? Are they putting on weight? And I have a conversation with the parents, spelling out what the options are. And from my practice, while in the early part of my career, did some tracheostomy avoiding operations. My current practice is in a neonate. In an infant, it's either a tracheostomy or it's waiting.
So that's interesting. We'll come back to that tracheostomy avoiding operations in a bit. I remember as a registrar back in the last century being, we would consent to the parents for an MLB and a tracheostomy, because if we diagnosed a cord palsy, they got a trachea on the spot. That's not my practice now. I tend to make the diagnosis, and unless they're really in extremis, I would then sit and watch for a week or two on the unit and get our tracheostomy practice nurse to come and chat to the parents and make the whole thing a little bit softer. Is that everybody else's sort of general approach? Because Mike.
For us, I mean, our cardiac surgeons are wildly anti-tracheostomy. So I suppose it depends in your patient whether what is the nature of your AVSD. If it's something so that they can stick something up through the groin and fix, then and he needs a tracheostomy, my threshold might be a little bit lower for a tracheostomy. I mean, I don't mean on the same sitting, but generally speaking, our cardiac surgeons get very upset if they're going to have to split the sternum if there's a tracheostomy.
Yeah, that's a good point.
So that's a consideration, and of course, I think as we get better at things like BiPAP, it can buy us a bit of time before committing one way or the other. And also, of course, the other thing is that if their wonky heart is unwonted, they might actually go from a not quite coping with a marginal airway to coping with a marginal airway.
Okay, that's a fair point. Anybody just routinely stick them on anti-reflux treatment on an empirical basis? I know some people would take that approach, not particularly. And would everybody get a salt assessment? To be honest, we never used to, but we always do now when there's a unilateral or a bilateral. They seem to wind up NG fed for a bit, and then they have several assessments, and some of them are okay and some of them aren't. Okay, that's fine. Now, let's just move on a bit. We're heading towards 8 o'clock, but I'm quite happy to keep going as long as the rest of the panel aren't broken. Are you all okay?
Yeah.
Yeah, you're keen to get back to your wine, I know. A few things I'd like to say very briefly about bilateral vocal cord palsy, which Ben's already touched on. You have to be absolutely certain, first of all, that you're getting wide abduction, and that's a lovely picture of wide abduction of the vocal cords. So that's what you like to be able to see. Paradoxical vocal cord movement happens when almost everybody is asleep. And it's just the passive movement of the vocal cords because of the Bernoulli effect of the gases going in and out, and the cord is sucked inwards. So you could be conned into thinking the child's got a bilateral cord palsy because it's so deeply anaesthetized the cords aren't moving. And in many ways, doing awake nasendoscopy is a better way of looking at cord movement. But eventually, when the child is anaesthetized, the vocal cords will start moving again. And we've got this expression, a watched vocal cord never moves, that I think came from Manchester, either you or Ian. Because you're basically sitting there while the child wakes up, and you have to keep the laryngoscope in while the child wakes up, because almost the last muscle in a child's body that comes to life at the end of a general anesthetic is the abductor mechanism for the vocal cords. And you're sitting there with either it's in suspension or you've got your hand holding the laryngoscope and you get a very sore arm. And this is why I tell the registrars that we have them in theatre so they can do this bit, because it goes on and on and on while they wake up. And I think we just got a very brief clip at the end there. Just as the child wakes up, normally the arm's coming over to grab the laryngoscope. You sometimes get a couple of wide abductions as it wakes up, and then you've got to stop. So it's a very good idea to video it, but you do have to cling on till the bitter end. Hasna, what's going on? What's going on here? I'll stop it there.
I can't actually see the vocal cords. I can see the child's got a nasogastric tube.
Yeah, exactly.
And it almost looks like the arytenoid sucked in.
Yes.
So you can't see the vocal. So is it a negative pressure effect? I can't see any full abduction, but
yeah,
I can't
when you get
cords clearly, and I can't see whether it's with inspiration or expiration, but there doesn't appear to be any complete abduction.
Well, and that's absolutely right, Hasna. I really like this video because I think when you first look at it, or if you only got a fleeting glance at the nasendoscope, you'd be tempted to call this laryngomalacia. Yeah. And in fact, when you really get down to the vocal cords, you realize that what you're looking at is a bilateral vocal cord palsy. And I use this to illustrate the idea that it's actually rather harder to tell the two conditions apart than you think in paper. You see quite a lot of children who've been diagnosed with laryngomalacia but wind up with a tracheostomy or wind up intubated or something else who've actually got a cord palsy. So although you might think it's an easy thing to do, I think in practice it's not as easy as we think. Right, we've already pretty much covered on that. When do we consider doing a tracheostomy? You know, when they're in extremis or they're failing to thrive. Ben, I think I'll come back to you at this stage. So you've got a child who's now, you've just done a tracheostomy. They're say 4 weeks old with a bilateral vocal cord palsy. What are you going to tell the parents about the future? Let's say this child is otherwise essentially healthy. Doesn't have a neurological problem or a cardiac problem. So this is a sort of idiopathic bilateral cord palsy.
Yeah. So I mean, there's a very significant recovery rate, and in children who don't have neurological problems elsewhere, it's probably more than 50%. But it's a very unpredictable condition, and not a well understood condition either. it's probably an upper motor neuron lesion. The exact neurophysiology of this is very complicated. But essentially, in all children who get a tracheostomy, there is a period of watchful waiting, looking for recovery, and there may be some usefulness of laryngeal EMG during that period to try and get some more prognostic information. And then there's this discussion about at what point you give up waiting for recovery and start to think about.
Okay, if I stop you there, how often are you going to look at the vocal cord movement over the next few years?
Standard, if I did tracheostomy, I'd look at 3 months.
Yeah.
And then see how they're getting on. And if it's absolutely nothing, I'd probably look at 3 months again. If we're starting to see some recovery, 3 to 6 monthly, it would be a typical interval.
Okay, that's fine. And of course, if the cord movement re-establishes itself, you'd consider a decannulation sort of protocol at that stage, presumably.
Yes.
Yeah.
Yes.
I'm not going to go into the decannulation protocol particularly, but that's fine. So what you then hit on is the idea of doing something surgical when there's no hope of the movement coming back, to try and get the tracheostomy out. Yeah. And you were just about to say what sort of stage you consider doing that.
There is no consensus around the world about what age you do lateralization surgery, start to consider it. And we have opinions from 6 months up to 15 years. And there's been definite complete recovery in an 11-year-old reported in the notes. So you can in the literature, so you can get late recovery. It definitely happens. But actually, on a practical level, after 2, if you haven't got recovery, you're getting pretty unlikely. And the other thing which is important is children with established tracheostomies do well at home, but as they're starting to go out of the home environment into nursery or into school, the tracheostomy becomes a huge issue. And so realistically, in my practice, we're looking at trying to get them decannulated when they're going to nursery, which is sometime between 2 and 3. We're starting to think about lateralization surgery if we've got nothing happening.
Okay, 2 and 3. I tend to leave it a bit longer than that, but that's fine. Neil, you mentioned that you were doing something a few years ago to try and avoid a tracheostomy. What were you doing?
I was doing laser cordotomy.
In the neonatal period?
Yeah, to try and avoid it. But actually, the fact that that a very significant number recover made me very anxious about the idea that I was doing something irreversible to children's vocal folds.
Yeah.
When there's a realistic expectation that a significant proportion will end up with a normally functioning larynx at the end of the day. So now I'm basically, I haven't done that for years. Okay.
Mike, what do you do? What timing-wise, do you have a policy?
Well, I think just to go back a little, I think it's really important that these kids get valved earlier on. And when you're asking about do you get speech therapy, evaluation and involvement, I think they're really important to get the kids valved early. Otherwise, I think they get almost probably some sort of disuse atrophy, I suppose. It's not the correct term, but
no, it's fine.
My experience of people, the kids who have got this and haven't been valved early, they don't really cope so well. I leave it quite late, actually. Partly because of hope that things will get better, and I suppose partly because there have been some kids who as they get older, they've actually refused to have anything done, strangely, and a number of kids in their teens have been successfully decannulated, even though their cords don't move. I mean, I have certain theories about why that is. Now, I was thinking about that recently. I was just wondering whether a denervated vocalis muscle just becomes more atrophic, and actually you actually have a little bit more space in the gap.
Yeah.
I don't understand why, because I've got a few kids whose vocal cords clearly don't move, and they've never moved, and you block them out with a decannulation protocol, and they seem to be able to breathe perfectly well.
They always have.
Say perfectly well. I don't mean run up 2 flights of stairs, but well enough, to.
Yeah, I mean these kids once you've decannulated them in that position, they are stridulous and they are noisy, aren't they? But they generally seem to be better off without the trachea in that specific indication. So, staying with you, Mike, for a minute. So you've decided, let's say a child's got to 4 or 5, and you decide it's time to decannulate it. How do you lateralize vocal cords? What particular?
My preference is to use a suture.
Okay, so suture lateralization. Anybody else? Neil?
I have done sutures and I have done posterior grafts.
Yeah.
I think I have fewer problems with a posterior graft, either endoscopically or open. The last one I did was a posterior graft that I decannulated just before we closed down for you-know-what. For
you-know-what, yes. We're not allowed to mention the C word, by the way, if anybody's worrying what that was about. It could also be applied to cycling or even cholesteatoma, but it's the panel talking about, because some of the panel have had a little weary of the virus. Okay, Hasna, what's your technique? If you get to this stage, do you have a preferred technique?
So I don't tend to do any of these things. I have tried a posterior glottic split and dilating, but I always worry about the integrity of the larynx, and are you doing something irreversible? I do think, sorry, going back to what Neil said about chordotomies, there's some really good reports, but I haven't seen them published yet, of using Botox to avoid tracheostomy. So injecting Botox, and apparently these children are not getting dysphagia, which sort of lasts 3 to 4 months, and avoiding a tracheostomy is neonate. But until those reports are published, I don't know.
Yes, I've looked into that. I mean, you presume you stick it in the posterior cricoretinoid. I'm trying to remember the anatomy.
Posterior cricoretinoids.
Yes. There's a little bit of margin for error, I think, as well, isn't there?
Well, I think it's incredibly hard in a small, spontaneously breathing child, but the reports that they're saying and the numbers of babies they've used it in appear to be good. But until you've got proper data that's published, I think you have to be very careful in doing something like that.
Yeah.
I mean, with sutures, I have limited experience. Laser chordotomy, I only have experience in adults, and I think the issue is you're compromising voice for airways. That an issue. Laser retinoidectomy, that's my experience in adults. With the endoscopic cricoid split and balloon dilatation, actually I have seen that work without having to put a posterior glottic graft in.
Okay.
And I've done some posterior glottic grafts. One of the children aspirated for about a couple of weeks afterwards, which was horrible to see because I thought I'd caused more damage than good. But other than that, we're looking at laryngeal reinnervation, but it's such early days.
I'll come back to that in a bit, Hasna, if you don't mind.
Yep,
laryngeal reinnervation. Ben, do you have a preference?
I have tried all of those things. The one I don't do is the chordotomy. The chordotomy is, in my book, is a barbaric operation. You laser right into the center of the cord, often in small children, trying to avoid a tracheostomy, and I'm sure it's very damaging for the voice.
Yeah.
If you're going to do a laser, the idea is to do it very posteriorly and preserve the membranous vocal fold for voice. So laser arytenoidectomy. None of them are reliable.
Yeah.
The sutures are definitely not reliable. Posterior grafts are in fashion, but we're seeing more and more children having 1, 2 posterior grafts and are still struggling. So again, it's not a perfect solution. The laser arytenoidectomy is an ugly operation, but we've had some good results with that. It probably is the original, but they're all limited, and I don't honestly think I can say that one is better than the other.
Okay. Just for the Chinese watching, this video demonstrates or the results of a right suture lateralization. So you pull across the cord of the suture, and after a few weeks it almost completely reverts, except there's a tiny little notch there left, which just makes the difference in letting you breathe. And it's I've done this a few times and it works okay. I find it quite fiddly though, and getting the sutures.
But the other thing, Mike, is that it doesn't preclude you do. It's a very simple, very quick operation that doesn't preclude you doing a posterior graft afterwards if you need to.
Okay.
You know?
And I think although it sags back, it often limits passive adduction. So you often get
adduction. Yeah.
Adduction. You get a sort of splinting effect of the suture, which stops it getting sucked inwards.
Yeah, that's fair enough. I'm afraid I've nicked this video from YouTube, and I'm not quite sure what sort of laser that is. When I've done this laser chordotomy, I just use a CO2 laser mounted on the microscope. And effectively what you're doing is dividing the membranous vocal cord from the vocal process of the arytenoid there, trying to preserve as much of the membranous vocal cord as you can for the preservation of voice. Bruce Benjamin used to refer to the anterior 2/3 as the phonatory glottis and the posterior third as the respiratory glottis. It's a slightly arbitrary division. So essentially what you do in a laser chordotomy is make what you think is going to be a neat little cut along there, but it turns into this great bomb crater full of charred tissue, and it looks completely dreadful at the time you do it. But funnily enough, rather like the suture one, my experience is it tends to heal up remarkably quickly and not look that different. Again, just with a little notch that makes all the difference. So I've done this as well. I don't really like doing it. I think they all aspirate a bit afterwards, whichever technique you do, because they can't close their cords literally. I am quite keen on the idea of a posterior graft, but for the life of me, I've been waiting for a few years to try it, and one hasn't come along. I've certainly seen videos of Neil doing it. I've seen the pictures. It looks really desperately easy, Neil. I can't imagine anything could possibly go wrong with that.
No. Absolutely no profanity in the operating theatre.
No, probably takes no more than 7 minutes or so, I would have thought. Anyway, so I'd quite like to try this. The reason I'd like to try this is that the vocal cords themselves are remaining entirely unviolated. But of course, you are moving the back apart a little bit. I don't think there's any consensus on which is the best operation. So we're nearly done.
Mike, you can do a chordotomy with scissors.
I haven't tried that.
It's not as barbaric.
You could do it with a coblator, I imagine, Mr. Bateman. Could you?
Yeah.
I imagine you tried that. Actually, you probably could do it with a coblator. It'd probably be quite good.
Oh, the little MLW ones would work really well.
Right. So that's nearly everything. And I thought, Hasna, if you could just give us a couple of minutes on what use vocal cord reinnervation is at the moment clinically, that would be interesting, because it's not something I have a lot of experience of.
Yeah, no, I have to say credit really to Kate Heathcott for introducing the technique to the UK. And also we've got a very good consultant neurophysiologist, David Allen, and Andrea Burgess. I'm just part of that team. Yeah. Basically, when we're talking about vocal cord reinnervation for bilateral vocal fold palsy, we're talking about selective reinnervation with the aim of restoring respiration while maintaining normal phonation. And what you're doing is you're using one of the branches of the phrenic nerve to reinnervate via cable graft the posterior cricoarytenoids, then thyrohyoid branch, which is rarely used, to attach that to the stump of the recurrent laryngeal. You have to carefully select your patients, and one of the things I would say is you have to be careful of patient expectation. A lot of these children have had trachees for a long time. There have only been 8 done in the world, which is John Paul Murray and Marshall Smith. We did one here in Southampton recently. I haven't seen their published report, but John Paul Murray has had very good success with his children decannulating apart from one, and having good exercise function. The one we've done, I think we didn't really quite appreciate the psychological aspect of how children become very dependent on tracheostomies. And also, these children get worse before they get better because you're completely cutting the nerve supply. So for the first 2 weeks in the first one we've done, this child was actually had dysphagia for 2 weeks and couldn't really swallow. And the aim in France is they decannulate early, but because of the distances children are coming from here, that's not practical. So, and recovery can take up to 24 months. But I think it's something that it's very much in its infancy, but it does make sense to me. I know to some people it doesn't, but we'll know in the future if it works or not, and with case reports. But I think you have to be very cautious in recommending it, and it's really a last-ditch attempt. We've not gone to anybody. People have approached us, and we've been very open and honest about it. And I think very much like, you know, Botox, if that works, is actually going to be a much better option, avoiding the tracheostomy in the beginning. But I think with all these things, you have to be very cautious and have very good collaborations, very good databases, and document everything, and be very open and honest with parents, because some children this won't work in, and you'd have essentially cut their recurrent laryngeal nerves.
Yeah, but yeah, so you're burning your bridges again.
Yeah, although
that's not.
Although potentially for brachial plexus repairs, they use the whole of the phrenic. Yeah, you do have to be incredibly careful.
Okay, fantastic. Thank you very much for that. Now, that is the end of the meeting, or the end of the webinar, whatever you'd like to call it. Have any of the panelists got anything more they want to say? No? Desperate to get back to Netflix. Your hot bikes or whatever it is you're going to do this evening. Well, I'd like to say thank you to all of the expert panelists. I think it's been quite good. I'm very sorry about the cock up at the beginning with the wrong meeting ID. I think it might be helpful to get someone more technologically savvy than me to help if we do another one of these. So if people could either WhatsApp or email just some sort of feedback and constructive criticism, as well as saying send us the right meeting ID, that would be very helpful. Right, thanks very much, Neil, Ben, Mike, Hasna, thanks very much. See you soon.
Thank you.
Thanks so much.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye, everyone.